So I think this is probably best approached as what I'll call a both and conversation rather than an either or decision. I think targeted screening is a very logical starting point, right? Particularly for children with first degree relatives where risk is significantly higher. But it's really important, I think, for pediatricians to appreciate that upwards of 90% of children who develop type 1 don't have a family history of it, which means that a purely targeted approach is going to miss many future cases. And so that's why awareness is really important. We in endocrinology now widely understand that T1D is a progressive autoimmune disease. It's driven by immune mediated destruction of pancreatic beta cells, which are the cells that are responsible for producing insulin. And that's a process that can unfold over months or even years before symptoms appear. And it can actually be detected through autoantibody screening during that silent phase. So, in practice, targeted screening should really be considered the floor, not the ceiling. And pediatricians can start with higher risk populations, family history, personal or family history of autoimmune disease, et cetera, while also becoming comfortable with discussing broader screening as part of routine care, especially as access continues to improve. And I think ultimately the take home is that it's not about being caught off guard. Autoantibody screening can identify children before symptoms set in, before insulin is required, and before the presentation can potentially be life threatening. So I think the biggest missed issue is sort of conceptual. It's that early stage T1D is not clinically obvious. The earliest and most important marker is not going to be a symptom. It's going to be the presence of islet autoantibodies. There are four that are recommended by the American Diabetes Association: glutamic acid decarboxylase or GAD, insulin autoantibody, IA2 or islet antigen 2, and zinc transporter 8. So once a child has two or more of those autoantibodies, that individual has early stage T1D and should not be described as simply at risk. And the progression to clinical type 1 diabetes approaches 100% in those who have evidence of multiple autoantibodies. And so, what clinicians can miss before overt symptoms appear are these like little subtle metabolic changes that signal progression from the earliest stage of type 1 called stage 1, which is when blood sugars are normal, into stage 2 when blood sugars become mildly abnormal but not really clinically obvious and cause symptoms. So pediatricians may miss a little bit of rising glucose variability, sometimes some intermittent post-meal hyperglycemia or high blood sugar, mild impairment in fasting blood sugars, or an A1C that may still be, normal, or even like in pre-diabetes range, but rising slowly over time. And the other thing that can get overlooked are these what I'll term sort of soft warning signs, which is a child who may come in for other reasons and parents know that they're drinking a little more, using the bathroom a little more. Maybe they have some fatigue, or just declining stamina. And the challenge is that by the time classic symptoms are really obvious, that child may be close to or already in diabetic ketoacidosis. And so this is why screening really matters, because it shifts us from reacting to symptoms to identifying disease biology much earlier. So the earliest marker of T1D progression is immunologic before it's ever going to be symptomatic. Yeah, it's it can be touchy and sensitive. So I start by acknowledging that it can feel counterintuitive, right? And even a little bit scary. I think parents often think my kid is healthy. Why would we test them? And I completely understand that. I am a physician, a pediatric endocrinologist. I've been living with type 1 myself for almost 33 years. I have kids. I've had those same hesitations when I think about screening my own children. There can be fear and uncertainty and even guilt. So having felt that myself, I try to normalize that first. And it's not like the pediatrician needs to have personal experience in order to normalize that, but I think validating those feelings goes a long way. And then I try to reframe the purpose of screening, right? That it's not labeling a child as sick. It's about understanding the risk earlier so we're not caught off guard by it later. And many parents or many families actually that I've cared for told me that they really have never heard of T1D risk or screening until after their child presented with really serious complications like diabetic ketoacidosis. And that's really what we're trying to change. So I'll often explain it very simply, like type 1 diabetes develops in stages. We now have the ability to detect it before symptoms start, and that gives us time to do things like monitoring, education, avoid an emergency presentation. And the upside is that we could potentially leverage research and other advances in therapy. And it's actually Autoimmune Disease Awareness Month, and it's a great opportunity to have these conversations. It can create a space to talk openly about risk and reduce stigma around screening and emphasize that this is just one part of a broader proactive approach to health. And I think that when families understand that screening is really just a blood test and that knowing earlier could help prevent a crisis, then it can help shift that conversation from fear to empowerment. Yeah, it's a great question. Um, so identification of early T1D would absolutely trigger a referral to pediatric endocrinology, right? This is not going to just fall on the shoulders and the plates of pediatricians. But it doesn't remove the primary care provider from the picture. It actually, in my mind, makes their role more important, not less important. So primary care providers become these really essential partners in reinforcing the care plan, right? They help families understand what to expect, and they ensure continuity between those specialty visits. And truthfully, right, they're often the first point of contact when something changes. And so the awareness of the child's risk and risk trajectory, right, which sort of stage of diabetes they're in, becomes really critical. And I think where this would show up in sort of an everyday clinical decision making sense is during sick visits. So a child who previously would have been managed as like a routine viral illness, something like that we see all the time and sort of become callous to. If you know that child is at risk for or has early stage type 1, would now warrant a sort of different level of attention. And primary care providers would then have a lower threshold to ask about symptoms like increased thirst and urination, would have a lower threshold to check for glucose or ketones, and then would be able to escalate concerns or coordinate with endocrinology earlier. And so it really shifts anticipatory guidance and helps primary care play this really pivotal role in enhancing education and symptom recognition and when to escalate care. So I think it's endocrinology that's most likely going to lead like the staging and monitoring plan, but it's going to be primary care that really operationalizes it in day-to-day life. So there, there are many. The biggest misconception I would say is that if there is no family history of type 1 diabetes and no symptoms, then the misconception is that there's no meaningful risk to talk about. And that's really outdated thinking at this point. Family history matters for sure, right? It's the number one risk factor. But up to 90% of children who develop type 1 don't have a first degree relative with the disease, and type 1 can present in earlier stages long before all of these symptoms arise, right? So a related misconception to that is that type 1 is really only like real once insulin dependence begins. And we now know that, it's an autoimmune disease with really recognizable and well defined pre symptomatic stages. And that matters because if we can identify children earlier using screening, we can reduce diabetic ketoacidosis rates, we can improve family preparedness, we can create access to monitoring and subspecialty care and research studies and newer approaches as science continues to advance. So I think that the overall message to primary care is that we don't want to wait for a child to look sick before thinking about type 1 diabetes. Our understanding of type 1 diabetes has really evolved, and clinical practice should evolve with it.